Hello.
It started. Now we can begin the session.
Okay. Yeah. Good evening, everybody. So, welcome you all for the case discussion series from Karnataka Spice Route Council. Today we have a presenter, Dr. Ruby, who is a second year PG from St. John's Medical College, Bangalore. And we are very own moderator, who is Dr. G.D. Ravindran, sir. He is HOD, Family Medicine Department, St. John's Medical College, Bangalore. Welcome you, sir. We can start the presentation, Ruby.
Okay, ma'am.
Yeah.
Good evening. Today's case presentation is on cardiovascular system.
Just one small interruption, sorry. And anybody having any query or doubts, please post it in the chat box. It will be addressed as relevant to the topic, otherwise at the end of the session. Thank you. You can start, Ruby.
Yes, ma'am. Coming to the case session, biogeographical data. A 56-year-old lady who is married and has 2 children, a housemaid by occupation. She is a resident of Bangalore, belonging to class 3 of the modified Kupasamy socioeconomic scale. Her presenting complaints are breathlessness 2 months, dry cough 2 months, multiple joint pains 2 months. She was admitted on 22nd of October and was discharged against medical advice after 2 days. Coming to the history of presenting illness, a 56-year-old lady, a diagnosed case of hypertension, came to the OPD as complaints of breathlessness on exertion, which is gradually progressing over the past 2 months. Initially, she noticed to have mild difficulty in doing normal activities. She found getting breathless on washing clothes, cleaning the house, and while doing routine chores. Later, she found breathless even on walking for 100 meters, more difficulty to do her daily activities that led her to even quit her job. She also noted to have cough for these past 2 months, which was dry, not productive in nature, with no seasonal or diurnal variation. She also developed joint pain, initially in the right elbow. After 5 days, pain developed over her left knee, which progressed to left ankle, with no swelling. She also noted to have mild intermittent fever with no associated chills, along with joint pains, for which she was treated symptomatically. She says to have also experienced palpitation during these 2 months, which was abrupt in onset, especially during the fever episodes or during exertion, and settles abruptly when the fever subsides or on taking rest. There was no history of chest pain, orthopnea, PND, no history of hemoptysis, dysphagia, no history of dizziness, syncope, no history of hoarseness of voice, weight loss, or night sweats.
Ruby, can you stop here? Go back to your first slide.
Yes, sir.
Okay. Now, you have present. No, sorry, the second slide.
Yes, sir.
You have presented this patient with breathlessness, cough, and palpitation.
Yes, sir.
How do you analyze this breathlessness? What do you think is the cause for her breathlessness? She's a known hypertensive on treatment.
Yes, sir. Non-hypertensive on treatment. So the breathlessness occurs only during exertion.
Okay.
But while she is at rest, there is no breathlessness. So while she is exerting, she develops breathlessness.
Okay. So
it seems to be more of cardiac pathology rather than the respiratory pathology.
Okay. Okay. So in the respiratory pathology, they will not have breathlessness when they walk, is it?
They have breathlessness, but it won't. It might be there during rest also, and there will be other associated features like productive cough and any seasonal variations.
Okay. If she has got breathlessness and hypertension, okay, and you think it's a cardiac cause, what do you think is a possibility?
Because of long-standing hypertension, she can develop pulmonary hypertension.
Okay. So you mean to say she has got a left heart failure?
Could be, sir, because she's breathless on walking, so could be also left heart failure. But the negative history is like that she's having no orthopnea PND, so that is against left heart failure, sir.
Okay. You mean to say every patient with left heart failure should have PAD? Not necessary, no?
Yes, sir.
Then she also had cough for the last 2 months.
Yes, sir.
And it's a non-productive cough.
Yes, sir.
What do you think is the cause for this cough?
So maybe because of long-standing hypertension, the left atrium gets dilated, and that causes compression over the bronchus and can cause chronic
See,
cough.
when you hear footsteps, now you think of horses, not of zebras. A hypertensive patient has a dry cough. What do you think the possibilities are? She has no sputum production, no direct variation or seasonal variation.
Hmm.
If a hypertensive patient comes with cough, what will you think of?
So there will be pulmonary congestion. So
Why should pulmonary congestion is that there should be frothy sputum? No, she does not have any frothy sputum. Can antihypertensive drugs cause cough?
yes, sir. AC inhibitors and ARBs can cause cough.
Any other drug? Any other drug?
Participants from the group also can answer if you know the answer in the chat box.
It's difficult for me to handle chat box when I'm talking. So if you can see whether this thing is...
Yes, sir. If I find any
Yeah.
answer, I'll prompt it, sir.
Okay. Other drug that is used not so frequently, but olden days it was very commonly used, was beta blockers, no?
Beta blockers. Okay.
Okay. Now she has palpitations. What do you
Yes.
think is the cause for palpitations?
She might have developed arrhythmia.
Arrhythmia, okay.
Other issue may be other causes other than related to cardiac, like if she's having precipitating factors like anemia, fever episodes.
Why should anemia produce palpitations?
So because of fluid overload condition, fluid overload state, heart rate can increase, and they can feel that as palpitations.
So there may be tachycardia.
Tachycardia.
Okay. So when you are talking about palpitations, one group of diseases that can produce palpitations is arrhythmias. The second condition that can produce palpitations is when there is increased force of contraction. Okay, like for example, a person with aortic stenosis, aortic regurgitation more often, they'll present with palpitations. Now, when you take a history on palpitations for arrhythmias, can you differentiate what type of arrhythmia is there by listening to the history?
So based on their onset.
Okay, very good. Then? Okay, onset, what will you find in the history?
they say when they are doing some exertion, or that time abruptly palpitations occur.
So it can be an abrupt onset, or it may be because of
Gradual also.
gradual onset. Okay. Now, what are the arrhythmias which start abruptly?
Sir, any like atrial fibrillation?
Atrial fibrillation starts this thing, is it? Any paroxysmal tachycardia, supraventricular tachycardia, ventricular tachycardia will present with the abrupt onset. Gradual onset is seen in patients who have sinus tachycardia or sinus arrhythmias. It slowly, gradually starts. Okay, it goes gradually. Then what is the next thing that we'll ask for in the history?
Whether any associated syncope is there?
Okay. If the person has got associated syncope, how does it help you to diagnose what the problem the patient has?
Sir, can be due to low cardiac output. So it's something dealing with the predominantly left side of the heart.
Okay, then what else will you ask for? If you get the history that it is
And
sudden onset and this palpitation is continuous and it suddenly stops. Okay, so it tells you that this person has got a paroxysmal tachycardia. Okay, now next question is, whereas if the person has got a sinus tachycardia, patient will gradually increase in heart rate, and as it progresses and the stimulus for increased heart rate decreases, patient's heart rate will come down gradually. So whether it is continuous, whether it is abrupt stopping or gradual stopping. Okay. Next thing that you ask is, what happens after the arrhythmia stops? Okay. Does the patient pass large quantities of urine? If he passes large quantities of urine, what does it tell you?
So either the patient might be on drugs.
Which drug will make you pass large quantities of urine?
And diuretics.
When, which will also control the arrhythmia.
So diuretics.
Why will you give diuretics for arrhythmia?
No, sir. No, it's a side effect of like passing large.
Usually, when there is excess of urine is passed immediately after the arrhythmia has stopped, it's most likely to be a supraventricular arrhythmia, because atrium gets stimulated, atrial natriuretic factors are released, so the patient will say that he has passed large quantities of urine. That's how you differentiate from the history whether he has got a supraventricular tachycardia or he has a sinus tachycardia. Okay. Sometimes the patient, if they're a little smart enough, they'll tell you about missed beats. You know, patient has got ventricular premature contractions. He may have a compensatory pause, and the next beat after that will be a forceful beat. So a patient will be able to identify that there is a VPC with this history. Patient says, my heart rate is already, suddenly I find that heart rate is stopping. And after the heart rate has stopped, you get a forceful contraction and the heart rate becomes like the previous time. So it tells you that his history is there is a post-ventricular, he's having ventricular premature contractions. Okay. And if the heart rate does not change, there is no abrupt onset, no gradual increase, but it is present throughout the day and it increases when the exertion with the relaxes with the rest, it's more likely to be a structural change which increases the post-op contraction. Okay. So here we have a hypertensive lady who's got most likely to have a left side heart failure. and she has got a dry cough. And dry cough may be because of the drugs or because she is in failure. And she also has palpitations, which I'm not able to, the history is not very clear. We do not know what the cause of her palpitation is. In addition to that, you have also put to another story. She developed joint pain, right elbow pain after 5 days, and left knee, which progressed to left ankle with no swelling. Mild intermittent fever, no associated chills, along with joint pains, and was treated symptomatically. How do you interpret this history?
It could be an attack of rheumatic.
You meant to say patient had rheumatic fever? Okay.
And
The history of, if you see a rheumatic fever, what history will you ask in the past history?
so any history of sore throat
Okay.
previously.
Did you get any history of sore throat?
Yes, sir. 20 years back, she had a history of sore throat and multiple joint pains.
No, recently has she got sore throat?
No, sir. Recently, she didn't have sore throat.
Okay, fine. Okay, carry on.
Yes.
Next. Okay, go to the next slide.
Coming to past history, 20 years back, she had a history of multiple joint pains along with fever, for which she was diagnosed to have heart disease, for which no medications or injections were taken. During this illness, hypertension was diagnosed instantly, for which she is on tacrolimus and is on regular follow-up. Personal history, she's a mixed diet person. Bowel and bladder habits were normal. Sleep is reduced for the past 2 months, and she has a habit of pan showing for the past 15 years. Coming to obstetric and menstrual history, there's a history of 2 normal vaginal deliveries, which was uneventful both antenatally and postnatally, last childbirth being 26 years back. She has attained menopause at the age of 50 years. Family history.
Just stop here.
Yes, sir.
She has had, when was the last child born?
So 26 years.
Now the child is 26 years.
Yes,
so
sir.
when the lady was around 22 or 23 years old, she had the last childbirth. And
Yes,
both these deliveries are home deliveries or hospital deliveries?
Hospital delivery, sir.
Hospital. Did she have any problems at the end of her pregnancy? I mean, last trimester or second trimester of her pregnancy?
No, sir. It was uneventful.
Uneventful.
Yes, sir.
So she had something like according to your history, she had a history of rheumatic fever. Okay. And how many years after rheumatic fever did she become pregnant?
Because 20 years back only she had that history of sore throat and
Okay.
so it's actually up to
After her pregnancies were completed.
yes, sir.
Okay, fair enough. I accepted it. Okay.
Coming to the echogenogram, she is the eldest
Can you explain what is this echogenogram?
So it is basically the echo mapping. Xenogram is showing the basically the family tree, and echo mapping is the stresses and the health conditions which revolve around that patient.
Okay. So in this lady, how is it happening?
In her family tree, she is the eldest in the family, with no other significant family history in her siblings. Only a history of CA endometrium in her mother who passed away, and she married and she has 2 children. Both are married. And coming to her echo mapping, she has some stresses in her life, like she has abusive relationship with her husband who is an alcoholic, and for the past 2 months she has lost her job. Therefore she has anxiety issues related to it, and also there is financial crisis at her home, as she has taken a huge amount of loan, and so these are her stresses revolving around her.
You mean to say she has no other social support? She has only stresses.
There is support from her siblings, but these are her stresses, which might have some contribution to her.
I'm asking this question precisely because you said patient was discharged against medical advice. What was
Yes,
the
sir.
reason for her to leave the medical advice? Was it financial or because she had nobody to look after her?
It's not exactly the financial or the support system. It's about the whether the option of during like the option of the diagnosis when it came up, they were not ready to accept the diagnosis, and also the treatment further when we advised about the treatment, they were not willing to do that treatment.
That should have come up in your genogram, no?
Yes, sir. Yes,
Okay,
sir.
go to the next slide.
To summarize the history, 56-year-old lady diagnosed case of hypertension and unknown heart disease, presented with breathlessness with non-productive cough and palpitation and joint pain. Probably the system involved would be cardiovascular system.
Okay.
The differential diagnosis would be hypertensive heart disease, congestive cardiac failure, acute rheumatic fever leading to mitral regurgitation.
What points in the history make you think that she is likely to have mitral regurgitation?
There's a significant past history showing suggesting that she might have had an episode of rheumatic fever.
Commonest, this rheumatic fever after healing will be a mitral stenosis, no? Why did you talk about mitral regurgitation?
Because mitral stenosis would be presenting little more of like hemoptysis, PND, orthopnea.
Okay. Right. But you have not covered in your history, I mean, your differential diagnosis, what is the cause for a palpitation? She had rheumatic fever, you said hypertension, you said CCF. What is the cause for a palpitation?
So new onset of arrhythmia.
Okay. Fine. Go ahead. Next.
On general physical examination, she was conscious, cooperative, and oriented to time, place, and person. So, vital examination, she is febrile, pulse is 80 beats per minute, irregularly irregular, no volume pulse, and with no radiofemoral delay or radioradial delay. Her peripheral pulses were felt. BP was 86/60 millimeters of mercury in right upper limb, examined in sitting posture. Respiratory rate was 16 counts per minute, abdominothoracic. SpO2 was 98% on room air. Her BMI was 21 kg per meter square, and her JVP was 4 centimeter above the sternal angle and was normal.
Okay. Tell me, what are the causes for irregular pulse?
So, one is atrial fibrillation. Another could be ectopics.
What ectopics? Ventricular ectopics, atrial ectopics.
So ventricular ectopics.
Then? Okay, this much if you know, it's okay. In this patient, how did you measure the blood pressure? You said he's got irregular pulse, so you decided that this person has got atrial fibrillation. How would you measure the blood pressure in this patient? You understood what the difficulty is? Because
yes,
the Korotkoff sounds will depend upon the ventricular contractions. Some of them will be forceful, some of them will be less forceful. So in atrial fibrillation, how do you check the blood pressure?
So the initial first sound would be taken as systole, and the latter part, which is
if the forceful contraction is there, you get a first sound which is very low, high. See, the easiest method for when you are talking about if you have irregular pulses, to measure the BP 3 times and take an average of that.
yes, sir.
Okay. And for a person in family practice, there is no need to do all this complicated way of measuring BP using Korotkov sounds. It will be difficult for a family practitioner. If you are doing MD medicine or cardiology, that's a okay question. But for us, family practice, if you have taken the BP 3 times and average the BP, that is enough for us for practical purposes. Okay.
Yes, sir.
Now she has got a BP of 86/60, and you said you went on telling us she's hypertensive. Why is the blood pressure dropped now?
So that it could be a new onset of valvular heart disease, which might have caused her to have a decreased cardiac output.
Which new onset this thing will decrease blood pressure? Okay. Now, next question that I'm going to ask you is, did you look for any collaborative evidence to say this person has been having long-standing hypertension?
So
Clinical examination wise. Suppose somebody says, I got hypertension for a long period of time. Okay, today the person has been taking on drugs, it is controlled, blood pressure drops, but still you want to make sure that this person has got hypertension. Maybe he had a myocardial infarction and the BP dropped. You do a fundus examination to see whether the person has got long-standing hypertension, long-standing changes in the retina. That is one way of confirming that share there. And other thing that is a patient has got irregular pulse. Okay, and you said JVP is 4 centimeters above the sternal angle and normal. If a person has got irregular pulse, what will be the JVP?
So irregular pulse, mostly the patient might have AF. So the AF.
I know patient has got AF. When a person has got AF, what will happen to the atrial contraction?
The A wave will be absent.
Okay, so A wave will be absent. So how can this be normal?
Yes, sir.
And not just picking up for the sake of picking up. No, you must know the risk, why it cannot happen. Okay, go ahead.
So there's a query in the chat box. What should be the gap between the BP readings? The
Which
3 BP reading that you mentioned to pick up the hypertension.
There is no specified gap between this. It only says, most of the books say, if you do measure it 3 times and if average the 3 times, that will give you an average blood pressure of the patient. There's no time gap, whether it's 5 minutes or you have to wait for half an hour or 1 minute. You can just measure it one after concurrently and take an average of that.
Thank you, sir.
Okay, so this finding is not right.
Yes, sir.
Okay. Go to them.
Pallor was present. Icterus and other icterus cyanosis, clubbing, and edema were absent. There were no any cutaneous signs of atherosclerosis or infective endocarditis or acute rheumatic fever.
Okay. Now, can you enumerate what are the causes, the cutaneous signs of atherosclerosis for the other people who have joined us?
So there will be xanthelasma and there will be arcus senilis.
Arcus juvenalis. Arcus senilis we will see in older patients.
Age.
Juvenalis we will see in that. Okay, then
Tendon xanthomas will be
okay.
there.
Okay.
And
Signs of infected endocarditis.
so there will be anemia,
Okay, so there will be pallor.
okay. Splinter hemorrhages,
Okay.
clubbing. Then patient can have splenomegaly.
General examination sign, no? Splenomegaly is a
Yes,
this thing, no? It's a abdominal exam, general examination.
Osseous nodes.
Okay. Osseous node.
Janeway lesions.
Okay. Can you describe osseous node?
So it's a painful, palpable nodules present in the pulp of the fingers or toes.
So remember osseous node, 4 P's. Pulp of the finger, P-shaped. No, it's a small one. It's not a large one that you'll see. Painful, purple in color. That is osseous nodes. Janeway lesions, where will you see?
Janeway lesions will be in the thenar and hypothenar eminences.
It will be in the palms. Okay, you'll see it in the palms. And what type of it? It's a papular rash, macular rash.
It will be non-tender macular rash.
The macular rash. And what is a macule?
More than 1 centimeter.
Macule is a lesion which is discolored, which is not raised about the surface of the skin. Okay, macular rash will be there. Then you get ecchymotic patches, you get petechiae. These are the signs of infective endocarditis. What about the acute rheumatic fever? What are the signs?
The patient might have subcutaneous nodules.
Okay, nodules.
Sydenham's chorea.
Where will you see the nodules?
It will be present in the extensor aspect of the joints like elbow.
So you'll see it over the olecranon process. Okay, you'll see it over the scapula. You'll see it over the spinous process. You'll see it over the occiput. You'll see it over tender Achilles. Okay, so you will see that. What is the next thing that you see?
So erythema marginatum.
Okay, describe erythema marginatum.
It will be like a serpentinous rash.
Where will you see it? On the face, hands, legs?
More on the lower limbs.
It will be seen at the lower part of the abdomen and upper part of the thigh. So below the umbilicus you will see, and just above the thigh you will see this rash. Okay. So erythema marginatum, then what will you see?
Then Sydenham's chorea.
Sydenham's chorea. Sydenham's chorea occurs how many days after the person develops acute rheumatic fever? Sydenham's chorea is not seen immediately. It's seen as a chronic thing at least 2 weeks after the person has developed. Okay, then what else will you see? You will see joint swellings. Okay, so there is a migratory joint swelling. So you'll have one joint which is enlarged, another joint will be subsiding, and patient will have a lot of pain in that place. Okay. Then, so these are the signs. Unfortunately, the last time when I saw erythema marginatum was 20 years ago, and we still keep teaching it because rheumatic fever has disappeared. This is just so that you will remember this, because some examiners are very fond of asking these questions. Okay, next slide, please.
Coming to the systemic examination, cardiovascular system. On inspection, trachea appeared to be central. There was no precordial bulging. Apex and apical impulse were not able to be visualized. The skin over the chest wall was normal, and there was no sinuses or pulsation seen.
Okay.
On palpation, trachea was central on palpation. Apex beat was palpated at the sixth intercostal space. 0.5 centimeter lateral to the midclavicular line, shifted laterally but not downwards. It was a tapping apex beat. There was no thrill, no palpable P2, no parasternal heave. Hepatojugular reflex was negative. Coming to percussion,
Wait.
cardiac.
You said the apex beat is shifted in the sixth intercostal space, 0.5 centimeter lateral to midclavicular line. Normal, abnormal.
So abnormal.
Abnormal. Okay. So it is shifted outwards, not downwards. Okay, fine. And you said a tapping apex. What is the tapping apex?
It is not a forceful apex, but and not sustained.
It's a tapping apex. When you say it's normal apex, when you say it's a heaving apex, when you say it is hyperdynamic apex.
So if it is not forceful and the S1 is loud.
See, when you're palpating, you're not auscultating. No, how do you know the first heart sound is loud?
So if it is not forceful, it can be either normal or tapping. But in case of tapping,
you have said it is tapping, so I want to know how you made this guesswork of tapping.
So there was it was not sustained. It was not a forceful or a hyperdynamic.
When you say it's a heaving apex,
when it is sustained for some time and then comes down.
Sustained means how long should be sustained?
Like 2 to 3 seconds, sir.
2 to 3 seconds. I see. So if the person has got 60, heartbeat is 60, 2 seconds of this thing is sustained, that means it will go on to, heart rate will come down to 30, is it? See, these are questions which are asked, which many people make, do not talk about it properly. One way of escaping from this type of question is, in my experience, this is a tapping apex. Okay, that was all right 30, 40 years ago. Now, if you say it's a tapping apex, you must give some criteria for it. Okay, instead of talking about tapping apex, let us talk about heaving apex. Normally, in a normal apex, the apex beat, the finger is not lifted more than 70% of time. The finger is not lifted. If it is more than 70 to 90% of the time his finger is lifted, it is called a heaving apex. Okay, and there are two types of heaving apex. One is called a sustained heave, another is called a ill-sustained heave. When you say it's a sustained heave, the finger is lifted throughout the systole. And usually this happens when there is concentric hypertrophy, like in a patient with aortic stenosis. If the person has got aortic stenosis, all the walls of the cardiac muscle is enlarged equally, so it gives a sustained heaving apex. So it is called as concentric hypertrophy, and the cause for it is aortic stenosis or hypertension. The second thing is called ill-sustained heave. That means it does not sustain up to, it's more than 70% your finger is lifted, but it does not sustain for 90% or 100% of the time. Ill-sustained heave is seen when one wall of the left ventricle is increased more when compared to others, classically seen in patients with aortic regurgitation. Okay.
Yes,
Okay, tapping apex is an apex which just lifts your finger, does not last for more than 30% of the systole. And tapping apex Some people consider normal apex also as tapping. And if you say it's a tapping apex, some people consider that it's the presence of first heart sound, which is palpable. Okay. So between tapping, you have normal apex is less than 50% of the time. Between 50 and 70% of the time, when the finger is lifted, you call it as hyperdynamic apex, which causes all the causes, which increases tachycardia, which increases the left ventricle dilatation to some amount of left ventricle dilatation to take place. So when you say it's a tapping apex, you are implying that this person is likely to have as mitral stenosis. Then you said there is no thrills. That means all over this thing you did not find any thrills. Okay. No palpable P2 and there's no parasternal heave. So what does this tell you on palpation?
The patient does not have pulmonary hypertension.
Okay. And if he has no parasternal heave, what are the causes for a parasternal heave?
Can be due to right ventricular hypertrophy.
Okay. Only right ventricular hypertrophy?
In case of long-standing hypertension, which again signifies causes right ventricular hypertrophy and causing.
Okay. Tell me what forms the right border of the heart?
So the SPC and the right atrium and the IVC.
Right atrium, right ventricle, and then you get the IVC causing that. Okay. So the left parasternal heave may be because of a right ventricular hypertrophy, like you said. It may be also because of right atrial hypertrophy, which is very rare. Clinically, we don't consider it. But much more important than that is to think of a left atrial enlargement. See, left atrium is posterior. It is not straight like this. So because it is posterior, it pushes the right ventricle. So when there is a large left ventricular enlargement, left atrial enlargement, it gives to a parasternal heave. So a left parasternal heave may be because of left atrial enlargement, most common cause. It may be because of right ventricular hypertrophy. Very rarely, it may be because of right atrial hypertrophy. Okay. Okay, then you said HGR negative means what? Hepatogeocular reflux.
Reflex is negative, sir.
Okay, fine.
On percussion, cardiac dullness is normal.
It doesn't matter. Go back to auscultation.
Yes, sir. Auscultation, mitral area, S1 was loud but was varying in intensity of loudness. S2 was audible. There was a low-pitched diastolic murmur heard at the mitral area without any radiation, best heard with the bell of the stethoscope at the end of expiration in lateral position.
Okay, stop here. How do you know that first heart sound is loud? Normally, in the aortic area, the second sound will be louder than the first heart sound because the aortic second sound is formed by closure of aortic valve, and aortic valve in this right in the aortic area is very close to the chest wall. So normally the second heart sound will be louder than the first heart sound in the aortic area. And if you say the first heart sound is loud, that means in aortic area, the first heart sound must be louder or equal to second heart sound. Then only you call it as a loud first heart sound. Okay. And if the person is having varying intensity of loudness, you cannot say his first heart sound is loud. Okay. Tell me causes for a loud first heart sound.
It can be due to volume overload conditions like anemia.
Anemia.
And
common condition for a loud first heart sound.
The mitral stenosis.
Very good. So mitral stenosis on the left-hand side. What will you get in the right-hand side? What is the equivalent of mitral stenosis on the right side?
Tricuspid stenosis.
Very good. So mitral stenosis is the commonest cause, and applying the analogy, you can get a tricuspid stenosis producing a loud first heart sound. Okay. What other sounds conditions will increase? Why should anemia produce a loud first heart sound?
Due to volume overload condition, volume overload state.
Any condition that produces tachycardia will give rise to a loud first heart sound. So it will be anemia, pregnancy, thyrotoxicosis. Okay. In addition to that, whenever there is a condition where there is a short PR interval, you will get a loud first heart sound. Can you tell me the condition where you get a loud first heart sound because of short PR interval?
The Wolff-Parkinson-White syndrome.
Okay. WPW syndrome is condition where you get a loud first heart sound. Okay. So adding the corollary to this is a soft first heart sound is seen in patients who have got mitral regurgitation or tricuspid regurgitation. Anybody who has got bradycardia will give rise to a soft first heart sound. Okay. Then you said the second heart sound was audible. Then you said patient had a low-pitched diastolic murmur heard at the mitral area. Okay. Best heard with the bell of the stethoscope at the end of lateral rotation. Was there an opening snap?
No, sir, I couldn't appreciate the opening snap.
Okay. You had heard a mid-diastolic murmur. Was there any presystolic accentuation?
No, sir, there was no presystolic accentuation.
Okay. If the person has got a presystolic accentuation, what does it tell you?
The left atrial enlargement.
Left atrium is contributing for the cardiac output. So when the person has got atrial fibrillation, you will not get a presystolic accentuation. And when you have atrial fibrillation, it's very difficult to talk about the loudness of the first heart sound. If the first heart sound is soft, then you know that there is calcific mitral stenosis. Okay, this is a clinically that you wouldn't look for it. Did you look for a tricuspid area? Did you look for a tricuspid regurgitation mound?
Yes, sir, but I couldn't appreciate a tricuspid.
Pulmonary area?
No, sir.
P2 was not loud. Okay, fine. Go ahead. Next.
Sorry to interrupt, sir. We have 10 more minutes before the meeting ends, sir.
Okay. No problem. I'll finish.
In pulmonary area, S2 was louder than S1, but there was no evidence of pulmonary artery hypertension. And the tricuspid area and aortic area, both S1 and S2 were normal. There were no murmurs.
Okay, fine. Go ahead.
Other systems were found to be normal.
Okay, fine.
And the provisional diagnosis would be valvular heart disease, probably mitral stenosis, probable etiology being acquired rheumatic, patient being in AF, not in failure, no evidence of infective endocarditis or acute rheumatic fever or pulmonary artery hypertension, with hypertension, long-standing hypertension.
What is the evidence for hypertension? BP is 80/60.
Yes, sir.
Okay. So you talk about valvular heart disease, mitral stenosis. Okay, rheumatic fever, not in failure. Okay, next slide, please.
So the plan for treatment would be going for routine investigations like hemoglobin.
Don't tell me routine. Why do you want to do hemoglobin in this patient?
So she had pallor.
Okay.
So,
if she has got pallor, how is that? Why is it necessary to know what type of pallor it has, and what is the implication for a patient with cardiovascular disease?
If an underlying cardiovascular disease is there, the anemia could precipitate the.
So you need to document anemia and treat. What other thing can be there with there is a valvular heart disease and patient develops anemia?
The infective endocarditis.
Very good. So you think of infected endocarditis. Okay, fine. Other reason would be if the person has got a valve replacement, they can have hemoglobin dropping because of hemolytic anemia that they can have. Why do you want a total count?
In any source of infection, because she had joint pains and mild episodes of fever
So-
in between.
Okay, fine. Then why do you want a serum creatinine?
Due to long-standing hypertension, she was on treatment, so
You wanted to check. Okay, I'll pass that. Why do you want a urine routine and microscopy?
so same in this, like long-standing hypertension, any urine albumin is present.
She has got acute rheumatic fever. She is having fever, and you want to do a urine microscopy. And what will you find in the urine microscopy?
Is there any hematuria?
Microscopic hematuria indicates what? In a patient with valvular heart disease.
Infective endocarditis.
Very good. So you'd like to infected endocarditis. Now, on your investigations that you have written there, you said patient had most probably acute rheumatic fever. What are the investigations that you should do for acute rheumatic fever?
ASO titers.
ASO titer. Okay. Then ESR.
ESR and CRP.
Why was that not done for this patient? Okay. So you have to get a ASL or titer. Why do you want ASL or titer?
To know whether she is having acute rheumatic fever.
Tell me Jones criteria for diagnosis of acute rheumatic fever.
The major criteria involves polyarthralgia, carditis, subcutaneous nodules, erythema marginatum, and the Sydenham scoria. And the minor criteria includes the fever, CRP, and the ESR levels. And then also laboratory investigations.
Essential criteria is what?
Sir?
Essential criteria for diagnosis of acute rheumatic fever. Past history of acute streptococcal infection.
Yes, sir.
So you do all the TSL or titers to see that this person has got streptococcal infection. Okay. You ask for a chest X-ray. You have a chest X-ray ECG?
Yes, sir.
No, go back to that.
The hemoglobin was 8.8, total count were 8,400, creatinine was 0.8.
Now, come to the ECG and chest X-ray.
Yes, sir.
Your interpretation of this.
So the ECG is showing with absent P waves and irregular rhythm and narrow QRS complexes.
So it shows R waves in the RR interval is varying across the thing. You're not seeing a P wave and the baseline is undulating. Classical features of an atrial fibrillation. ECG. Okay, next slide, please.
So the chest X-ray.
Can you read this X-ray?
Chest X-ray of a 56-year-old lady. Trachea appears to be central with the no rotation with adequate exposure. Bony and soft tissue appears normal, and the cardiac about cardiac. There's the straightening of the left heart border, and there's a increase in the transverse diameter of the heart. Could be cardiomegaly, and there is a pulmonary artery dilatation with peripheral pruning.
Why is the left heart of the heart this thing dilated?
So because of the left atrium enlargement,
So what forms the left border of the heart?
So the aortic knuckle and the pulmonary trunk and the left ventricle. Left atrium is
Aortic knuckle, pulmonary, vein,
pulmonary.
then you have auricle, then you have the left ventricle. Okay, because the left auricle atrial enlargement is there, you will get straightening of the left border of the heart. Okay, is there any features of failure in this patient, in this chest X-ray?
So there's no blunting of the CP angles.
Okay, so there is no pleural effusion.
And there is no.
Where will you see curly B lines, curly C lines? Where will you see increased venous markings in the upper lobe? Battering. Is there battering appearance in this patient?
So there's no battering appearance.
Okay, fine. So what is your final diagnosis?
It could be acquired rheumatic heart disease, probably mitral stenosis.
Okay. Then?
With no evidence of.
She's in atrial fibrillation.
And in atrial fibrillation with
mitral stenosis. Maybe she's. Now, what you have presented, I cannot make out whether she has failure or no failure. Okay, I take this thing. Now, if she has got atrial fibrillation, as a general practitioner, would you anticoagulate this patient?
Yes, sir.
What's the chart score in this patient?
So doesn't. So score should be more than or equal to 2 to start anticoagulation.
In this patient, how much is it?
It's actually.
Okay, one thing is, since we have no time, next question I want to ask is, would you give a rheumatic prophylaxis? Because as family practitioner, patient will go to the cardiologist and come back to you, no?
Yes, sir.
I'm not talking about what mitral stenosis you are going to do, surgery and all that. I'm just asking what a family practitioner should know. One is he has to know anticoagulation, when to start. Second is he talk about should we give rheumatic prophylaxis for this patient.
So we have to provide.
Otherwise, what is the criteria for giving rheumatic prophylaxis? In a person who has got only acute rheumatic fever, in a person who has got chronic valvular heart disease. And she has got a chronic valvular heart disease. Since she has chronic valvular heart disease, she needs rheumatic prophylaxis for life. Okay.
Yes, sir.
Third question, that is, when will you recommend infective endocarditis prophylaxis when you are referring this patient for some procedure?
So any procedure which involves dental procedures or
no, that is, you tell me what is the latest infective endocarditis guidelines. If you do not know that, please go and read.
Yes, sir.
Okay. Now, that is the third thing that you have to talk about is what will you talk to the family? They'll ask, no, what is the prognosis? If you go for surgery, what will you get for that?
we have to counsel them about getting surgery as soon as possible, because the patient can end up in cardiac failure.
Okay. So you'll refer them for the surgery, cardiologist to deal with it. Okay, I think it's already 8 o'clock. Do you have any more time, ma'am, or is it going to be closed?
We can conclude the session, sir, actually. You can
Okay, fine.
give your conclusion for the case
So-
and then your
So
suggestions.
what I wanted to illustrate here is the 2 points that you be there. When you come for exams, if this type of patients are kept, the examiners will see whether you have medical knowledge. And the second thing that you look is whether you take into account the family practice effect of it. Whether do you know how the family is, what is happening, and how do you manage practice in general practice. They will not be bothered about whether you say do what type of surgery you do, whether you'll do valve replacement. But basic thing is you should know about anticoagulation when you will give AHS, when you give acute rheumatic fever prophylaxis. And if the patient is in failure, you require management of failure. These are the questions that are usually asked when you go for exams in the DNB family medicine exams. I shall stop here. If you have any questions, please send it to the chat box.
There are no questions so far in the chat box, sir.
Okay.
Yeah. I think we can conclude the session, sir.
Sure. Thank you.
Thanks. Yeah, sure. Thank you.
Thanks,
Thank
sir.
you so much, sir, for such a lovely discussion and taking us through the basics of the case discussion and how to focus and give importance to the basics being a family physician and what to look for. Thank you, sir. And thank you, Ruby, for the presentation.
Thank you. Thank you.
Thank you all the
sir.
participants for attending the session. Thank you. We'll be ending the meeting now.